about, as was mentioned before, mortality in Chennai, which is one of the larger cities in South India, and the fourth largest in the country altogether, with some recent work that is probably going to show up on medRxiv anytime in the next couple of days, but you're getting an advanced look. Very thrilled to conduct this work for the first time, though our paths have crossed for years now, working together with Aisha on an actual demography related kinds of project, and not just on infectious disease stuff solely. But this follows on some work that I've been doing with colleagues in South India, and specifically in Tamil Nadu, for a number of months now. And I believe I spoke at your demography brown bag series last year, but maybe it wasn't about India. I don't know if it was about India or not, but I know I talked to you guys at some point. But in any case, for context, I think everyone's familiar with the fact that India has been among the most severely affected countries in the ongoing COVID-19 pandemic. The country implemented a very strict lockdown nationwide early on, in about March 24th was the first date of that. In response to the fact that cases were coming in, there was a major super spreading event associated with a religious congregation in Delhi in March, and quickly from there, cases did fan out across the rest of the country, including in March, cases that had already been detected in Chennai in particular, which is the kind of commercial and economic center of Tamil Nadu, and was the first location in that state to report cases. First wave progressed through August, November kind of range here on the chart of today's most recent update of COVID-19 cases in India. But as we all know, what that time called B16172 variant, or now we call Delta variant, probably took hold in India first, or at least was first noted to be rising to prominence in India, and kicked off a very severe wave over the late spring of this year that was utterly devastating to much of the country. Certainly medical capacity was stretched thin, if not completely overwhelmed. And many may recall sort of horrific images that came around that time of makeshift kind of funeral pyres and arrangements to sort of handle the just extraordinary influx of mortality that was unfortunately occurring around the country. The context of this has of course been a point of some controversy. There's an article I just wanted to draw your attention to in New York Times today, sort of looking into policies between the government of Narendra Modi and the ICMR, which is their top public health and medical authority in the country. And I'll leave that there if you want to delve further into some of these issues that have occurred. Of course, where this leaves us is that there's not a widely accepted figure for just how bad COVID got in India, in particular in the second wave. And back in the spring, shortly after or around the time that the second wave was peaking, there was an article in the New York Times putting out some kind of back of the envelope numbers or thought experiments about how severe things might be in India. Of course, one of the challenges that comes when we estimate the burden of disease, and in particular mortality associated with any infection, in particular in a setting where testing of all infections is not achievable, there may be issues that arise with infections that are never detected, and thus deaths that occur that are never counted as part of the COVID-19 toll. And so just as an example of what this was taken to look like in some figures from the New York Times, thinking through what these scenarios might look like. As of that time, 307,000 deaths had been officially reported. Today, that number is about 443,000. The number of deaths, however, that would correspond based on sort of back of the envelope reasonable approximations to an infection fatality risk with far more infections in the country would vastly overstate what was estimated. It's notable, in fact, that India is a country of about 3 to 1.4 billion people, almost certainly had more than 539 or 700 million infections at the time. Ongoing sero surveys, including in Tamil Nadu, showed 42% seroprevalence at the end of the first wave, and in Chennai in particular, 82% seroprevalence at the end of the second wave. So we are really looking at a scenario of essentially, uncontrolled transmission and almost, for a first order approximation, nearly everybody probably having been infected in this pandemic. So we, in the course of working with my colleague Ramanan Laxminarayan, who runs a institute called the Center for Disease Dynamics, Economics, and Policy, and is also appointed at Princeton University, and colleagues from the governments of the states of Tamil Nadu and Andhra Pradesh have done a number of studies trying to delve a little bit more closely into the epidemiology of COVID-19 in this setting. And one thing that actually caught our eye very early on was that there were some interesting features of the deaths reporting that were at least part of the subject of an earlier paper around this time last year, and then one that came out a couple weeks ago, which took a closer look at a particular city where an enhanced surveillance protocol was developed. So I'll leave these links here or these just titles here if you want to refer to those. Background: Tamil Nadu's in the, as I mentioned, the far south of the country. It's it's not necessarily one of the wealthiest states individually, but it is a better off state as compared to, in particular those, more towards the north. Despite not being the wealthiest, it is known within India for having a fairly effective public health model and healthcare delivery, primary care model. Just by way of background, when we first looked at cases that were being reported in comprehensive surveillance from Tamil Nadu and the adjacent state of Andhra Pradesh about a year ago, so right around the time that the first wave was cresting, if you will, we could see that there were some departures from what appeared, to be the mainstays of COVID-19 epidemiology in countries like the United States. So here I've plotted from that paper data on the age distribution of cases and deaths, as well as the incidence of COVID-19 confirmed case status and COVID-19 mortality as reported by age group. And what we can see is that in the United States and many other settings, where there's a obviously older age distribution to begin with, there's a concentration of deaths generally towards the very oldest age groups, and also a slightly higher kind of, or actually this is on the log scale, so substantially higher reported incidence of disease in the oldest age groups. In contrast, we actually saw sort of a plateauing, if anything, or reduction in reported cases towards older age groups, and likewise a plateauing in deaths towards older age groups, where the mortality risk, for instance, at the ages of 75 to 84 didn't really appear at all different from among people who are 85 years and older. And so this raised a really interesting question that we actually had to, go back and forth with reviewers about of what we could make from this. This meant, necessarily that deaths among older adults were specifically being missed, or being missed to a greater extent than deaths in other age groups in India, or if there could be some kind of alternative, socioeconomic confounding or something like that going on, where the people who survive to very old ages are better off and better able to avoid getting sick. We entertained both possibilities in the paper, but data that's since come has really, I think, shed light on which of these is the more plausible situation. So in the paper that came out a couple weeks ago, we were able to estimate in a setting of very enhanced case detection, the case fatality risk, as well as based on a sero survey that was conducted in the city around the same time, a cumulative kind of infection prevalence by age group, and the proportion of deaths that were reported as COVID-19 deaths in alignment with the seroprevalence. And what we were able to see here was that towards older age groups, the apparent case fatality risk didn't look a whole lot different from many other settings. The study site Madurai, India, is here in gray, and it's kind of the first of each block of age-specific estimates. But that at younger ages, it looked like a far more severe spectrum of disease was being captured. When we looked at the infection fatality ratio, it did look like there was substantial kind of under detection of deaths in the oldest age groups. Here, looking at 80 plus, we have almost 2 log difference in the estimated infection fatality ratio relative to the range of estimates that came from a meta-analysis of IFR type studies in a number of other settings with, in this instance, more competent surveillance both of infection and also demographic surveillance, importantly, including in Kenya where better demographic surveillance was in place. So we could see sort of, early on from these other studies that something must be going on, and it does look essentially like, at least relative to the reporting of um, of uh, of deaths in other places, there may be some kind of, particularly poor ascertainment of deaths occurring among older age groups, likely, based on the CFR analysis, based on the fact that some cases are essentially never getting diagnosed and their deaths are getting recorded. Once someone was diagnosed, they had equal or near equal risk of dying in Madurai in this instance, but Tamil Nadu more broadly as well, for the oldest age groups, whereas a very substantial number seemed to be essentially missed from surveillance altogether. And when we compared what we were observing in terms of the observed deaths per deaths expected based on seroprevalence data, we could see that it was an undercount by at least about 9.1 relative to a pooled estimate of IFR estimates from other studies. We would expect 9 deaths for every death that we observe. So this suggested something might not really be completely right about deaths reporting in this setting. Of course, this has all been, so far a very indirect way of looking at the issue. Serosurveys, and in some instances, there were household-based mortality questionnaires that have been used to say that maybe the burden of death due to COVID-19 in India is greater than what's been reported widely, but questions still persist, and this kind of inference is obviously suboptimal for making conclusions about something as important as how many people have died of COVID. So first, one question you might ask is whether infection fatality risks are truly transportable across settings. I mean, for all intents and purposes, they have not looked terribly different once they're stratified appropriately by age and sex, although there are, issues that might still arise with a different distribution of comorbidities and different status of clinical care that people who are experiencing severe disease might receive. And thus, it would be preferable not to work solely from a model-based kind of reconstruction of deaths from seroprevalence or something like that, and rather look at real deaths that occurred. Likewise, we might have questions about who agrees to participate in serosurveys that are used to determine infection prevalence, as well as household-based questionnaires to determine, mortality. And then last, ultimately, what we want is evidence that the deaths that we are saying might have occurred did in fact actually happen. That would be far more satisfying than just saying, well, it looks like there should have been a lot more deaths than were reported. So that's what we set out to do in this study. We were motivated by several examples from the literature in higher income country settings. For instance, this study by colleagues at Yale, Dan Weinberger et al., which looked during sort of the early period of the epidemic in New York City. Or actually, this is United States, but there were several other analyses stratified to places that had been hit particularly hard, and showed that sort of a baseline estimate of deaths that should have occurred in the US was plotted in this dotted line. Those attributable to COVID or reported COVID deaths were plotted here in blue and showed kind of, clearly going well above and beyond the normal rate of deaths that occurred. But then there was also this kind of gray area of additional unaccounted for deaths that were clearly associated with the COVID pandemic, but not necessarily diagnosed as being due to COVID-19. So, after this study came out, there were a number of others, including, at smaller levels, even here in California, by colleagues looking at the extent of excess mortality. Unfortunately, one of the places where studies of this nature would be most interesting is naturally low and middle income countries, where presumably, the ability to capture all severe cases of COVID and disease surveillance might be poorer. However, there are also very few settings with reliable vital registration systems that could enable similar analyses of all-cause mortality data to look for a departure from pre-pandemic levels. In India, vital registration, I'm sure that there's actually people in this demography group who can explain it far better than I can. So I'm going to try my best and hopefully not embarrass myself or say something too vastly incorrect. But there are 2 key systems used for official deaths and mortality surveillance in India. One is the civil registration system and one is a sample-based registration system. So under the law, all deaths and births must be recorded. And the civil registration system is essentially a framework which attempts to make that happen. Like many things in India, it is highly decentralized system, which localities and states are expected to customize to their own very unique contexts. Tamil Nadu has implemented a system where each district within the state, so Chennai, for instance, is an admin level 2 district within the state of Tamil Nadu, where heads of households have legal responsibility for notifying all births and deaths that occur in the community, whereas healthcare attended births and deaths are notified by physicians or other healthcare personnel. There's various levels of delegation of further reporting and also confirmation and verification of deaths by other people who might come into contact with the deceased, as well as in particular police and first responders who might in some instances be the first to encounter a death that occurred in particular, or a birth for that matter, but in particular deaths. In sort of parallel to this, India runs a sample-based registration system, which does not try necessarily to capture all deaths, but or all births or demographic events, if you will, but instead designates enumerators who monitor households and then also conduct surveys every 6 months to verify demographic events. And then this is then used to extrapolate to an estimate of how many births and deaths ultimately occurred countrywide, as well as within unique jurisdictions. And it's sort of used as a gold standard against which the performance of civil registration system numbers are compared. So if a country, or if a jurisdiction in India implements a sample-based registration system and then also implements its civil registration system and sees good alignment between the numbers, then that's a setting where the civil registration system is essentially accepted as a basis for comprehensive demographic monitoring. In Tamil Nadu, the CRS is considered very good. There's been found to be over many years running, actually, essentially 100% alignment between the estimates of births and deaths based on the sample-based registration system and what's recorded by the civil registration system in actually, assigning a birth certificate and death certificate to every individual who's born and every individual who dies. So this is consistent with the general kind of perception that Tamil Nadu is a state with good health and healthcare. So we use data from all death registrations from 2016 to June of 2021. So at the conclusion of the first wave and kind of the midway point of this year, to look at excess deaths relative to expectations under a continuation of pre-pandemic trends. And what I've plotted here in this figure is pre-pandemic based predicted deaths from a simple kind of regression based approach in the gray, with uncertainty intervals that account for parameter uncertainty in the underlying regression models, as well as just day-to-day variability in the number of deaths that actually end up occurring. And then in red, the observed deaths. And what we can see is that actually, there's very, very good alignment with expectations right until about the time of the first wave taking off, and even through the lockdown period when transmission was not yet very widespread in Chennai. There's not yet a whole lot of departure from our expectations and the trends that we had been observing. We can very clearly then see kind of peaks that occurred in association with what we'll call the first wave, although that is a sloppy ending to a first wave. There's sort of a period of elevated deaths occurring, as well as cases continuing to occur throughout the fall of 2020 up to essentially the winter, when it was widely perceived that COVID-19 was over in India. Seroprevalence across different jurisdictions generally ranged from estimates of about 30 to 50% at the time, and many of the restrictions were relaxed. Vaccine coverage was nowhere near as high as what had been achieved in places like the US at the time. And India was, of course, tasked with producing vaccines for not only itself, but much of the low and middle income world. Unfortunately, as we all know, the Delta variant did come in and caused a very precipitous increase in cases as well as deaths thereafter. And so this is a plot showing that ultimately at the peak of the first wave, cases were about deaths were about 2.5 times their normal levels. At the peak of the second wave, all-cause deaths were about 5.5 times their normal levels. So this, looks a little bit more stark, for instance, than similar plots of all-cause mortality and its departure from pre-pandemic trends in other settings where studies like this have been conducted, like Spain and the United States. I've also plotted how this played out in terms of the overall excess deaths with two slightly different model-based approaches for estimating that, yielding the blue and red lines here versus the reported deaths. These are a little bit misaligned in time simply because the date of death is what I'm plotting for the excess mortality, whereas these are dates of reported or dates of reporting for deaths due to COVID-19. But we can see in any instance that there is a whole lot of white space between the all-cause excess mortality relative to pre-pandemic observations and the number of deaths attributed to COVID-19 throughout both the first and second wave. Overall, throughout the period, mortality was increased by a factor of about 59%, and the number of excess deaths by age group is presented here in this table at the bottom. Most notably, the overall statistic is that about 6.5 excess deaths occurred for every 1,000 people. So about half of a little bit above half of a percent of the city of Chennai, if you will, died in association with the COVID-19 epidemic, or over the last year and a half of it. That number obviously is higher towards older age groups where there's higher risk of death due to COVID, as well as higher baseline mortality. Interestingly, in the youngest age groups, there's actually, if anything, been sort of some evidence of a slight reduction in mortality. I'll talk a little bit more about this and some interesting nuances of how this played out across different periods of the epidemic and periods and in age groups and sexes and stuff like that. But just keep in the back of your mind that this was a period when transmission of just about every infectious disease was all but stopped amid COVID control measures. That's been a widely reported phenomenon. We've skipped virus seasons. We've, as a result of eliminating transmission of viruses, in fact, stopped also a lot of the leading causes of bacterial death with bacterial associated acute respiratory infections that often lead to severe invasive disease, often in particular when they interact with viruses. And so there's been kind of precipitous drops in mortality in children across the board. Well, 80-something%, about 85 or 89%, I believe, of deaths among children under 5 in India are of infectious origin. And so the transmission of the kind of usual causes of death in children is probably a very the interruption of that transmission is probably a big part of what we see here in the reduction in mortality in the youngest age groups. The lockdown is a particularly interesting period in Chennai because it occurred essentially before there was very widespread transmission, and so the impacts of the lockdown on mortality might be particularly interesting to consider. What you can the alignment is not always perfect, but there does seem to be some kind of a precipitous drop around the time that lockdown started in the deaths among 20 to 29-year-old age groups, and at least a trend towards departures from usual mortality also during the lockdown period at the slightly older 30 to 39-year-old age group. And what we see in particular when we looked at the sex-specific breakdown was that much of this was actually occurring among men. Women actually did not have nearly as big of a reduction, and by the 30 to 39-year-old age group, it was their deaths did not depart from pre-pandemic observations for the same point in the year. But there was a greater than 50% reduction overall in deaths before there was widespread transmission among men aged about 20 to 29 years old. Of course, this is also a age group where most deaths are due to accidents and injuries, which might have been exactly what lockdown kind of intervention helps to prevent. And so it's an interesting thing, at least there, to note that there were sort of unexpected additional benefits of the lockdown. If you recall some press coverage and news about the lockdown at the time that it was being implemented, there was a lot of concern that it would be more fatal than COVID-19 would in India, and there was a lot of concern about impacts in low-income settings like India. And of course, that's does not seem to be how things played out, at least from these data. We do start to see, of course, cases were occurring, and there start to be evidence of increases in deaths among the oldest age groups, which might in fact be due to COVID at that time. Looking at the data, another way we can consider what the observed changes in mortality correspond to in relation to life expectancy estimates. So I've broken these down with your colleague Aisha's help by a year to look at how we can measure, the impacts of not just, number of deaths, but, what this means for life expectancy in Chennai. Comparing to the year 2019 as the last um, uh, pre-pandemic baseline year. For the year of 2020, we saw for men and women a roughly 1.2 year reduction in life expectancy. Accounting for the additional cases during the second wave, this estimate becomes closer to 3.8 or 4.5 for the year 2021 under different situations of what might happen for the months of July to December, considering first a return, in the most optimistic sense to pre-pandemic baseline mortality. Of course, this is probably not, this is probably a little rosier than the situation that will play out actually looks like. Alternatively, considering cases and deaths during the second half of 2021 as being approximately equal to what was seen in 2020, we see this less optimistic estimate of about 4.5 year reduction in life expectancy.
So I'm sorry. I'm sorry about that. Shit.
I muted myself in case I was causing the feedback, but I'm not sure that helped.
I think it was on their end.
Okay. I'm happy also, I talk fast and I'm very happy to take questions as they come up when the data's up there or at the end, whenever people prefer. So please feel free to jump in.
Feedback was entirely my fault. I'm sorry. When you went back one slide, the third line is saying if the epidemic ends today.
Essentially, yeah. If there's no more excess deaths from July onward, it looks like pre-pandemic mortality. If we account only for the second wave would be seen as having taken about 3.8 years off of life expectancy based on the mortality observed with that.
That's what's already happened if nothing more bad.
Yeah, exactly.
Thank you very much. Sorry about that.
No worries. And one measure I actually wanted to include on this, because I read a great paper by your colleague, Dr. Goldstein in PNAS, which discussed the measure of years of life lost among individuals who were killed by COVID-19. And we can actually estimate that in this kind of context by looking at the age distribution of excess deaths, how many remaining life years they had under pre-pandemic expectations, and say, for people who died, not necessarily, we can't always say, necessarily due to COVID, but for people who experienced pandemic associated excess mortality, how many years of life were lost. And this is, I think a really relevant measure because it highlights that these were not all frail, very old people on their deathbed anyway. These, there's a fairly, substantial amount of healthy life left to be lived among those who died. It's about 14 years for those who died in 2020 and 16 years in 2021 when there was higher burden of mortality in younger age groups as well. So last, getting into another dimension of what we're able to do here, excess mortality, of course, can be looked at the city level, but it's very interesting to look at more granular breakdowns of excess mortality. In India, people, there's different sort of sub-administrative geographic divisions of people, but one relevant one which we were able to look at in this data set was the postal index number code area that individuals resided within. So just by way of background, each postal index number or PIN code is the area served by essentially one post office. It's sort of like a zip code in the US, although sort of a smaller area in most settings, except maybe the island of Manhattan, I don't know. We were able to look at 70 PIN codes, which had over the course of the time series, over 1,000 deaths recorded so that we could establish at least, PIN code specific baseline mortality expectations. And then look at characteristics of the PIN codes that experienced relatively more or relatively fewer excess deaths to identify potential socioeconomic drivers of differences in outcomes of the COVID-19 pandemic in this kind of setting. And I wanted to emphasize that, we know in the United States very well that COVID hit the poorest communities hardest, and the most disadvantaged communities hardest. There's far less understanding of how that played out in a setting like India, where in particular, in Chennai, nearly over 80% of people are seropositive as of the end of the second wave. There were distinct periods of the epidemic which might have affected different communities, and then also there was differential kind of impact of lockdown measures and differential ability to comply with lockdown measures for people in different circumstances of life, as well as just differences in the nature of life in a setting where there's far larger family sizes, crowding, etc. So what I've plotted here are distributions across the 70 pin codes that we were able to look at in terms of the ratio of observed to expected mortality, so measures of excess mortality as a fraction across several periods. So the whole epidemic, we can see here how that looked. The early lockdown period, where it's really centered around very little, if any, impact, although sort of a substantial amount of mass on either side of that scenario. The first wave and then the second wave, when things are far on the more on the right hand side of the plot with higher ratios of observed to expected mortality. Doing these analyses and looking at the increase in excess mortality or decrease in all-cause mortality relative to pre-pandemic observations in distinct periods, we can see that the impacts of the pandemic and also related measures really had different kind of, they played out differently in different communities. Most interestingly, and sort of going along with the findings earlier about sort of, men, in particular young adult men, having fewer deaths during the lockdown, we can actually see that the greatest reductions, or the settings that had reductions in mortality during the lockdown, were in fact the poorest ones. So I've standardized all of these, effect size measures by presenting the increase associated, or the decrease in this case, associated with a 1 standard deviation unit change in each covariate measure for a bunch of different kinds of census measures that generally would suggest places with more economic deprivation, so ones with greater crowding, poorer housing quality, lacking water and sanitation kind of facilities, lack of resources like electric lighting, and reliance on solid cooking fuels, and then some socioeconomic measures like the proportion of the population that belongs to scheduled castes or tribes. How many households have key kind of index assets that are used to monitor well-being in the Indian census, and then how many households lack bank accounts. So we can see that in general, there were in fact fewer deaths or fewer excess deaths, if you will, in settings that had poorer socioeconomic status by this measure during the early lockdown, before cases were really widespread in Chennai. By the time of the first wave, there was not really a whole lot of difference across communities, at least based on these measures, in how badly they were being affected by COVID-19 excess mortality. These estimates hover close to zero and jostle a little bit around, with some above and some below the zero line, but generally there's not a very clear indication here of socioeconomic, at least community measures of socioeconomic disadvantage being associated with greater burden of mortality. This all changes in the second wave when we look at what happened in spring and summer of this year, when far and away, for each of these indicators, we can see that there was a greater degree of excess mortality associated with lower socioeconomic status by each of these measures for communities. So overall, what this yields is an excess mortality pattern, since just the over half of deaths that occurred in the second wave. That was far and away the dominant kind of event in India's pandemic and in deaths in Chennai. Certainly, we can see that overall there has been a higher mortality in the relatively more disadvantaged parts of the city. So I want to thank my colleagues from this work. We actually were able to do this work without direct government collaborators, which is a sort of a important and sensitive issue with sensitive data along the lines of all-cause mortality during the pandemic in India, whereas our previous work was all with collaborators within the government of Tamil Nadu. But my colleague Radhaman Lakshminarayan, who I mentioned before, and is a native man from Chennai, and was really instrumental in having a lot of context there to make an analysis of this kind possible. my colleague Aisha, who you all know well, my colleague Brian Wall, who's actually based in India from Johns Hopkins, and I have interacted with him since earlier days as a kind of respiratory disease person in general, and student Tejas Narayan at U Chicago. So we were funded by a bunch of agencies, thanks in particular to rapid grants from NIGMS through the Midas Network, and grants from NSF and Gates Foundation to support this work.
Great, thank you so much, Joe. We have a few questions in the chat, and I think I'll just call out the names of the folks, and maybe they could just unmute and ask the question. And I'm sure more will come in because that was a really great talk. So let me just scroll quickly, sorry. I think David Levine had a question about data from other places in India. David, do you want to ask your question?
Well, this is a devastating critique. This paper is so important, but you showed lots of states have high quality civil registration. So my damning critique is, why haven't you done this in 20 other places in India?
I mean, that would be ideal. It is not freely accessible information, I will say that, and I will leave it at that, and that all of the work is premised on us having, particularly through my colleague who is from Tamil Nadu, but also from our history of doing partnerships that directly work with the Department of the Ministry of Health and Social Welfare in that state. I think and we still had to go through a lot of clearance to be allowed to.
Enough said. I understand.
Stuff, so yeah,
that was my conjecture.
I think your question brings up a really good point of why have data not come out about all-cause mortality in India during COVID-19, and why for the first part of my talk are we reliant on these really crude, indirect, backhanded methods, like saying if this is the infection fatality ratio, and this is how many infections happened, then why are the deaths so low? So I mean, it's definitely a sensitive issue. Yeah.
I understand they're backward countries where science is influenced by politics. Fortunately, we don't have that issue here.
Great. I think the next question is from Ron. Hi, Ron. Do you want to unmute and ask your question? Ron and Josh worked on that PNS paper, and I think his question is related to that.
Yeah, great talk, great work. I really enjoyed it and learned a lot. I just have a small comment on the remaining years of life calculation, which is that really to do that calculation, you have to assume that at each age, those who die of COVID have the same remaining life as those who don't die. And so it's kind of an assumption of the calculation rather than a conclusion that the people aren't frail and on their deathbed. In any case, there was, I don't know, when we did our paper, we found one study that did lend some support to that assumption. But I have no idea what the circumstances in India are. Anyway, there really isn't any alternative, pretty much.
This is something we were able to look at. I mean, you raise a really good point. So first of all, so thanks for that. This is a pretty crude assumption. We know that every comorbidity under the sun is essentially associated with a worse outcome of COVID-19, up to and including death. In our earlier study that came out in Lancet ID, which looked at the city of Madurai, so sort of the next biggest city in Tamil Nadu, where there was a kind of really enhanced surveillance protocol and expansion of the standardized reporting items for comorbidity assessment among cases. We were able to look, and of course, like everywhere else, you can see that diabetes, hypertension, COPD, and stuff like that is all associated with the worst COVID outcome. However, there is a kind of really big difference from the US, where a lot of those, not necessarily all of those, but I mean the diabetes, obesity, actually looking at the next comment, and several of the comorbidities have a very different kind of age distribution in India as compared to what they have in the US, where in the US, everything kind of gets worse as you get older. In India, and particularly things like diabetes and the more prevalent hypertension, the more prevalent comorbidities that might be associated with worse outcome. In fact, have sort of a more youthward skew in their distribution in the population. So it might be less of a bad departure than the same assumption would lead to in the United States, where those comorbidities are certainly far more prevalent among the oldest age groups that are also the ones getting COVID and dying. However, I'm sure that that we would be overestimating, despite this difference, I'm sure that we're still overestimating, years of life left to live. Unfortunately, I mean, even in that study, I certainly doubt that that our prevalence of comorbidities among cases was as high as it is in the real world. About, for instance, half of diabetes cases in India are never diagnosed, as one instance of those comorbidities that you might be very curious to look at. But that's a really good point.
Thank you.
I think Dennis's question is next.
Sure. Thank you so much. Really interesting talk. I was just trying to put together the kind of first part of your talk and then your main results. And I was wondering if you could compare some of the interesting kind of underreporting patterns from the official COVID deaths to your excess. So I know excess deaths are different from COVID deaths, but assuming that the majority, and I wonder if you could learn something about the processes that are driving the underreporting of the COVID deaths, and that might be helpful for understanding India and maybe other places too, where there's not good all-cause mortality data available.
So the very short answer is that no, and no for the most unsatisfying scientific reason, which is that Chennai had a major redistricting in the year 2019, where the city was expanded to about twice its original size. All of the estimates I presented are following the area within the pre-redistricting boundaries. And mortality within the pre-redistricting, so old Chennai, if you will. All cases are reported at the level of new Chennai, which has way more people in it. However, even doing that and looking, I can actually go back to a slide because I had this, even when we look at, I'm not
I think you have to share your screen, Joe.
I have to share my screen. Let's share. So even when we do that really bad comparison of cases and deaths in all of Chennai versus our excess mortality in the subset of the city that is, represented by the pre-2019 redistricting, we can see that, we see far more excess deaths than what was recorded in the far larger population of the new administrative boundaries. But I don't think that we can necessarily make a super valid beyond lower bound, essentially, comparison. I think that the overall comparison here that was suggested by this was roughly 3x difference, or I calculated it was 4.01x difference in our estimate of excess mortality versus reported mortality, but with different population denominators. That's that's the minimum bound, and probably at least 2x difference beyond. So unfortunately, not as well as we would like to.
Yeah, but like the puzzling age pattern, and because I think if I remember right, you showed us that the reported deaths really don't make sense at the oldest ages, and there's you can't get leverage on that or anything from the.
Yeah, so so in our other city of Madurai, where we're doing a similar analysis now, we can look at that, but it's a smaller city. But the general, I think, conclusion that the earlier data suggested, based on differences in the IFR and CFR estimates by age, is that what's happening is there are a lot of older individuals whose infections are never ascertained and whose deaths are thus never attributed to COVID-19. And I think what's being missed, at least the bulk of what is being missed, is in older age groups.
Cool. Thank you.
Will, do you want to ask your question? We have a few more minutes.
Yeah, sure. Thank you, Joe. And this is really fabulous work. It's so impressive. You already talked a little bit about the sort of demographic distribution of comorbidities. My impression is that obesity, as you said, in particular, is such a strong comorbidity with COVID, and that tends to be much more distributed in younger populations. And I was wondering how that intersected also with socioeconomic status. When you were showing those initial results where we're seeing the smaller mortality effects in the lower SES groups, I thought, well, maybe this has something to do with the obesity or other comorbidity distribution. But then you showed the wave 2 where it flipped, And so I'm curious first whether you have any thoughts on those SES patterns, but also why this flipped in wave 2, these sort of SES patterns with COVID.
I think the main thing to think is that when we're looking at the lockdown period, which is when you see the flip relative to wave 2, there's very little COVID deaths going on at that time. There were, a handful of deaths being reported, not necessarily even a death each day due to COVID-19. Granted, that was also when testing was most limited, but essentially, we're not looking at COVID deaths for the most part in that figure, and I think that might be, the key issue. What is interesting though is that in wave 1 versus wave 2, when you do have real COVID deaths that you're looking at, you see essentially, a no gradient versus a strong gradient. If there is maybe, some factor of early on, the same was actually true in the US, that very early on, it was not necessarily in the first month, I'm thinking March, April 2020, there was not as great of a socioeconomic pattern. Although we were not under the same kind of lockdown as that early a point in our epidemic as India was on. So I don't know if the comparison is totally fair. With comorbidities, where it might be interesting is in particular that, a lot of the cases that happened in the second wave had to be reinfections. And maybe if there was, particular role of, despite reinfection being how you got infected, there's, risk for some adverse outcome and comorbidities really being the deciding factor in who upon reinfection ultimately has a severe outcome. I can see that maybe particularly heightening the issue, because we're starting from a population that had 41% seroprevalence in the time before the second wave. But I don't also have, quite honestly, the most mature understanding of the distribution of comorbidities in India by SES gradients, and whether it's uniformly, as socioeconomically kind of graded as it is in the US, or if there might be additional issues where, for instance, the people who live longest to oldest ages might have, comorbidities, or at least are more likely to, of course, get diagnosed with those comorbidities. I think there's more to understand there for sure, and it's not well done in this study. So
yeah, the Lassie survey has some really interesting data, including biomarkers on things like obesity, et cetera. So it's worth looking at potentially.
Yeah.
I'm sorry, you said there was a lot of reinfection, and I don't know anything about that. How do you know that?
Well, just based on the fact that you had as big of an epidemic as you had in the second wave, when 41% of the population was already presumably infected.
It adds up to more than 100. Okay.
Yeah.
David, I think you had one other question. Do you want to ask that before we wrap things up?
There was another study that did use the civil registration in 7 states with acknowledgement of the terrible data quality in Bihar and others. Are your results, they feel the same to me, but I haven't read either study carefully.
They are similar. That study used sort of 3 approaches. They used a serosurvey based approach, like I cited in our Lancet ID paper, which came up with very similar estimates, although not for necessarily the same areas, but broadly. That study actually also, they also had household-based surveys, and I don't remember their findings with the household-based surveys. They also said that there were more deaths than were reported, but they also looked at all-cause mortality in a similar way to what we're doing. And I believe that they also showed a lockdown effect, at least in some cities, I believe, but might be mistaken that Lucknow was among those cities. But I know that there was some reference to a reduction in deaths at the initial time of the lockdown, which is just interesting to note, because that was maybe one of the more surprising things. And if anything, a thing where I thought maybe we're looking at an artifact of a bad, predictive model for deaths. But the fact that that particular thing was also replicated in that study was a bit encouraging, that we're not only looking at, some kind of that there's some confirmation, and it's not just maybe an analytic issue.
Great. Thank you so much. Maybe we can all unmute again and thank Joe for a really wonderful talk. Thank you, Joe.
Thanks for having me.
And I think Casey is hosting a brief session with students.